Good afternoon, ladies and gentlemen. Welcome to the plenary session 2 of the first Bangladesh Congress on Epidemiology and Public Health. This is really a heavyweight session with very renowned speakers, all of them, the three of them. And we start with the first one, Professor M.A. Faiz. Actually, he does not need any introduction. Still, I will mention that he is a very renowned professor of medicine, and he is a leading infectious disease specialist in Bangladesh, having a lot of research experience in malaria and toxicology. And he was the founder of BITID Chattogram, and also he was the former Director General of Health Services in Bangladesh. He will speak on key infectious diseases, issues in Bangladesh, TB, influenza, typhoid. Before his presentation, I would like to remind that as per policy of the organizers, there will be 15 minutes total for each speaker, and at around 7 minutes there will be a signal. The speaker should finish by 10 minutes, so 5 minutes would be left for discussion. But in this particular case, the system is a little bit different, that each speaker will get 15 minutes, and after all the speakers presenting their papers, there will be a 15 minutes discussion for all of them. So we will not have question after the end of the individual speakers. Rather, we'll combine all the questions together at the end of the 3 presentations. So I would like to request the audience to keep their questions and keep the target speaker in their question. So I'd like to start with Professor Dr. M.A. Faiz. Professor Dr. M.A. Faiz, please. Thank you.
Professor Mohammad Liaquat Ali, Dr. Qazi Ahmad Jaki, distinguished panel speakers, learned audience. Assalamu alaikum and good afternoon. It is indeed a great honor for me to be here to speak in the first Bangladesh Congress on Epidemiology and Public Health on a common topic, the situation of communicable diseases in Bangladesh. All of us are aware that we are in the sustainable development goal era, where the pivotal important indicator is infectious diseases, 3.3, to end the epidemics of AIDS, tuberculosis, malaria, and neglected tropical diseases, and combat hepatitis, waterborne diseases, and other communicable diseases. And in addition, we are in the era of universal health coverage, where nobody will be left behind. The Bangladesh health sector, health population nutrition sector program, addresses communicable diseases like endemic, pandemic, and potential future outbreak through 2 operational plans out of 31 operational plans existing in the country. The first one is TB, leprosy, and HIV. Previously, there are 2, now this is a single operational plan. And in the second operational plan of communicable diseases, there are different diseases like malaria, dengue, chikungunya, kala-azar, filariasis, soil transmitted helminths, hepatitis, antimicrobial resistance, typhoid, and others. And I shall concentrate few minutes in this particular area. You know, TB is a program. Globally, it is very important, and in Bangladesh, it is really we are fortunate to have funding from the Global Fund as well as from the government. As a result, we have got good achievement. We have got strategy, we have got objective, and in the operational plan, there are 18 key activities. Our target is to end tuberculosis and also to reduce the mortality. Currently, TB new cases are 0.7%, and previously treated cases are 11%. These are MDR, I mean. We have got lots to do, particularly for reduction of the death and particularly incidence. Unfortunately, childhood TB notification is below the target. We are off track for the incidence and death. The TB is not yet, officially it is a notifiable disease, but yet to be implemented in terms of notification. We are yet to start in full swing the contact investigation. We have got, for leprosy, we already achieved the elimination less than 1 per 10,000 population. And now our problem is to have a zero disability by 2023. In HIV, in 2019, we had something around 800 cases of HIV, 105 of them in the FDMN, and totally in the country, little more than 6,000 cases of HIV are living in this country. Estimation is 13,800, 80% of them from the 23 priority districts. And the malaria, we are in the phased elimination by 2030. API should be less than 1 per 1,000 population in 3 hill districts, and elimination of the indigenous malaria by 2025 in other 8 districts. Last year, we had little more than 6,000 cases of malaria, only 9 deaths, 6 of them in one district, referred from different places. We have got good achievements like filaria elimination, STAs elimination. For Kala-Azar also, we have got tremendous achievement. During 2008, there were more than 8,000 cases. Now in the 2020, we have got around 100 cases. Half of them are PKDL and half of them are either VL or they are previously treated cases. In rabies, we have got tremendous achievement in terms of the mass dog vaccination and human post-exposure prophylaxis. And there are less than 50 cases of rabies death in a year. Unfortunately, there is no place in Bangladesh where the rabies cases can be treated. For dengue, we had very big upsurge. We all know in 2019, more than 100,000, nearly 200 deaths. In 2020, fortunately, few thousand death cases with single digit death. We are yet to start in full swing the activities related to hepatitis, viral hepatitis elimination. The strategy has been formulated for typhoid. We do not have any strategy. We do not have any action plan yet for antimicrobial resistance. We drafted, we formulated the policies, but we have to implement this. What is the last part of this slide? Other than COVID-19, which is a pandemic, we do not have any significant visible program for any of the illnesses mentioned below. As I mentioned, no one will be left behind as the target. Here, we are leaving behind many infectious diseases, except we noticed this morning about Japanese encephalitis and Nipah infection, which are causing almost every year cases here and there. We have got surveillance, but we are yet to have any significant program. For diagnosis of these communicable diseases, we have to have good history and physical examination, followed by some key investigations like simple blood examinations. These are all simple investigations. We are fortunate that for TB, we have got gene experts spread all over the country, including in some of the sub-districts as well. And with this same technology, this RT-PCR for COVID-19 has been expanded across the country, including utilization of this gene expert machine. We have got various other facilities. Some of the simple investigations like these rapid diagnostic tests are being utilized for both diagnosis of malaria, leishmaniasis, and other viral illnesses, but not yet implemented across the country for many other illnesses. Simple blood film and LD bodies, test X-ray, microbiological investigations, as we know, is very tremendously important, but we have got very limited capacity in medical colleges also, and also no facilities in district hospital. The other investigations like ultrasonogram, CT, MRI, these are very useful, not only for detection, but also for the follow-up of the cases. Coming to one of the important illness, severe malaria, where we are going to eliminate, although the simple blood film is enough, but advanced physical examinations like this simple fundoscopic examination is almost equivalent to examination by MRI. In this film, there are certain findings here, and in the fundoscopic examinations, by simple clinical bedside examinations, one can find these findings, as I see here, in the bilateral retinal hemorrhages on both sides. An interesting case, having this reversible vaso-occlusion as a spasm here, which was reversible in 1 week's time after appropriate treatment in the hospital. As we entered into a very important era where we need to have a genetic understanding of the microbes. Unfortunately, this facility is not available widely. In this slide, we see artemisinin resistance. This is a multi-center study. These areas, the resistance, artemisinin resistance has been found in GMS, Greater Mekong sub-region, not in Bangladesh and western part of Myanmar. The importance of this information is there. We have to have the molecular test, not only for malaria. COVID-19 is a bright example that we need this investigation. As we listen to our colleagues about the Japanese encephalitis, although there are over the last few years more than 300 cases and more than 100 deaths, and of those survivors, they are having havoc in the neurological system, as we see in this picture as well as in this MRI findings. Similarly, in the Nipah infection, over the last 2 decades, since 2000, there are almost 40 outbreaks with more than 500, more than 300 cases, 320 cases with 231 deaths, 77% mortality. Unfortunately, we are yet to have this any national program. We could utilize the knowledge for the potential pandemic illness into other areas. For tetanus, here we are following this dark group concept. Coming to some of the very important illness like post-Kallada dermal leishmaniasis, the cutaneous leishmaniasis imported from the Middle East, the chickenpox, the histoplasmosis in HIV, lepra reaction. These are the dermatological condition can be diagnosed in the ubadala level through hub and spoke approach, as we are using in National Eye Care, connecting Ubadala Hospital with the medical colleges. We learned a lot about COVID-19. Every day we are learning. The advanced investigations, besides RT-PCR, we need to understand about the genetic makeup of the virus to understand the changes. The advanced radiological investigations, CT scan can give findings. Here we find the occlusion of the pulmonary vessels and lung findings havoc here. Interesting findings through cardiac MRI, the perimyocarditis has been detected, almost suggesting like myocardial infarction, but really significant findings can be reversed by appropriate diagnosis. Post-survival, the post-COVID, the CNS mucorale presenting as brain abscess and stroke. Lots have been done about the management in the advanced stage with little success, except the utility of the dexamethasone in advanced stage. Unfortunately, during the early part of the illness, where the viral load is there, or for the prevention of the illness, the simple drug, which are essential for the low middle income countries, is not there. The drugs that are being utilized for the severe cases, unfortunately, we do not have capacity to treat all those conditions. I'm not going to the strategic objectives of COVID-19, but this is an opportunity to build resilience and sustainable system. So these 11 approaches, starting from this coordination to surveillance, etc. We listened since yesterday. I'm not going to those things. We are introducing new technologies. We have to use safely for those conditions. There are communicable diseases associated with non-communicable diseases. Mind that the non-communicable diseases, they may develop communicable diseases. At the end, they may die. Also, some of the non-communicable diseases are associated with communicable diseases. We shall listen to some of the next presentation about the non-communicable diseases. As we listen to the surveillance system, we can think about the integrated surveillance system for the various communicable diseases, having a model for neglected tropical diseases, but the early warning and response system through automatic feeding by getting signals through entomology or vector, epidemiology and human being, and then climate sensitive data and the location, so that we can predict and signal linked with response as we listened to since yesterday. We need to have the very strengthening surveillance system as we are proposing that this utilizing this digital health up to the sub-district level, and so that we can have a better understanding about the vector-borne diseases, viral diseases, waterborne diseases, airborne diseases, so and so. At the same time, we have to remember that we have to keep in mind that entering the house by silo, by individual program would not be fair enough. So we need to have an integrated entry into the houses, for example, for LLIN, for IEC, for MDA, combine, etc., combine along. As we listened in this very early morning, that the trained epidemiologist will be very important for the surveillance system. Similarly, trained ID physicians will be important for the healthcare system, as has been found here, that having this trained physicians, infectious disease physicians, will be very much useful for the better health, for better care, and lower per capita cost triple aid approach. The ongoing pandemic of COVID-19 provided enough reasons not to underestimate the management of infectious diseases across the globe, irrespective of the economic status of the country. For example, countries like Bangladesh, we have got tremendous development in diagnostic microbiology. We need improvement in molecular biology, modern investigations, contemporary methods of management. We require, particularly we require specialized, purposefully trained public health experts, as we are working in this, listening to this in this Congress. Also, please also consider the infectious disease physician supported by diagnostic and management facilities, which is currently missing in Bangladesh. Let me focus in the contemporary history. For the Midford Medical College was established, the Midford Hospital was established in 1858 with 251 beds, and Midford Medical School in 1875. At that time, in 1865 to 68, there were 250 bed Midford Hospital. Of them, 24 bed was infectious disease ward. We had an ornamental past history of communicable diseases, having Tropical Institute in Pakistan and the British last period at that time. Subsequently, the Tropical Medicine Institute was merged with the Institute of Postgraduate Medicine and Research in March 1972 with the argument the country should have one center of excellence for postgraduate training and specialized training. Unfortunately, we are very fortunate that a large number of organ-specific postgraduate institutes were established, except such one on infectious diseases until 2011, the BITAD was established in Chattogram. Infectious disease department is yet to be established in the medical universities. And so we need, I like to re-emphasize the essential necessity of public health and surveillance system. Till now, there is no practice specialty, academic specialty, and clinical department or division with infectious diseases in the country, despite huge burden of infectious diseases in Bangladesh. The region had several epidemic outbreaks in the last decade and ongoing pandemic of COVID-19. So the public health experts and communicable disease physicians need to develop purposefully to address these infectious diseases in holistic manner, providing specialized direct patient care, teaching and research. The management of infectious diseases requires this infrastructure development for providing patient safety, healthcare worker safety, as well as community and environmental safety with purposefully built ID ward and ICU and HCU, besides other armamentarium at the same time, having very strong community engagement at IEC. The momentum developed for having dedicated infrastructure for tackling infectious diseases during the COVID pandemic needs to be upheld. So I would like to recommend, I would like to propose to have dedicated public health personnel up to the sub-district level and clinical infectious disease department with human resources, defined training scheme, certification and career, like we are listening since morning, with career path in all medical college hospitals, medical colleges, medical universities in Bangladesh. The ID ward with human resources to be set up in all district hospitals, because district is a very big place, having 15 to 200, 20,000 to 100,000 population. That means 1.5 to 3 million population in a district. We need to have an improvement of the existing and setting up of the new infectious disease hospitals with adequate human resources. The human resources, particularly for public health and surveillance system, to be already started to be developed. As we listen to that, we need nearly 1,000 of human resources. We also need to have the curriculum development for infectious disease specialty with residency in infectious disease and in graduate courses, of course, needed. One option may be for the temporary to be a special service specialty of infectious diseases as an extension of medicine and perhaps pediatrics till enough human resources are developed. Mr. Chairman, in conclusion, I would like to say that trained public health human resources with skills in epidemiology and infectious disease physicians with dedicated infectious disease department or unit with human resources in major hospitals like medical university, medical college and hospitals, BITID, district hospitals, and ID hospitals, supported by equipped lab facility, will be part of resilient and strengthened health system. We aspire to have the achievement of sustainable development goal, having universal health coverage, without addressing appropriately the infectious diseases in Bangladesh through a resilient, strengthened health system. Possibly it will be nightmare. With this, I'd like to end here with profound thanks to my colleagues, and with this, I would like to thank everybody for kind attention and kind listening. Over.
Thank you, Professor M.A. Faiz, for the excellent and very relevant presentation. Kindly stay with us for the question and answer session at the end of all presentations. Dear audience, please save your questions for Professor M.A. Faiz. Next, we will invite another very bright and renowned professor of medicine in Bangladesh, Professor Dr. Mohammad Robed Amin. He has a vast research experience in non-communicable diseases, and which is a major problem in Bangladesh as well, like all over the world. And he's now serving as the line director of NCDC program in the DG Health Services. Professor Dr. Mohammad Robed Amin, please. I would like to remind that you have 15 minutes for the presentation, and we'll have a question and answer session at the end of all the presentations. Thank you. Professor Dr. Mohammad Robed Amin, please.
Thank you for a very nice introduction of myself into this wonderful conference that has been arranged by the IEDCR and many relative stakeholders. So I will not waste any time actually, rather I will be interested to start my presentation if I have time. Is it available to be seen actually? Can you see the slide?
Yes, we can see the screen. See the screen.
Yeah, we can see your screen.
I will be saying something about the epidemiology and current situations on the non-communicable disease, as has been said by our honorable moderator. And we will be starting to saying something about the current situation. So this is going to be a programmatic perspective, and let us start with this slide showing the SDG. As we all know something about the SDG, as has been said by all, that this is a conception for all over the globe by the WHO and UN Council. And the SDG 3 has been the most important part of the physicians all around the globe.
Professor Robizamin, please share your screen. Kindly share your screen. Your screen probably has not been shared with the people on Zoom. Okay, now it's okay probably. Is it okay for others? Oh, no, thank you.
Okay. So what I actually was telling about the sustainable development goal, the number 3 is a very important component for all the physicians around the globe. It says about the ensure the healthy lives and promote well-being for all at all ages. Now, among the non-communicable diseases in this, if you concentrate about the SDG, we have few targets, including the 3.4, 3.6, and 3.8. And underneath the 3.4, it actually reduce it that by 2030, we need to reduce the 1/3 of the premature mortality from the non-communicable disease through prevention or treatment. And being sure about that one, about the major mortality from NCDs derived from the cardiovascular death, including the ischemic heart disease and the stroke. Now, one important indicator has been set up is the mortality rate attributable to the cardiovascular disease, cancer, and diabetes, or chronic respiratory disease. And secondly, among the 3-4 target, another was the suicidal mortality rate needs to be as indicator. The 3.6 in the SDG is saying that the global death due to the injury from the road traffic accident need to be half. And we also need to have the death rate due to the road traffic injury as an indicator of 3.61. In the SDG, there's another component of the target is a 3.8, which is actually the World Health Organization framework on the convention of the tobacco control in all countries as appropriate. And for that one, indicator has been set up as a age standardized prevalence of current tobacco use among the persons age 15 years old. So that is the another area. And in our Bangladesh, actually, we have a 4 THP-NSPs running right now with a strategic objective and risk factor-wise the global level indicators of progress. So for the thematic area of the NCD and mental health, the strategic objective in the 7 and 8 of the 4 THP-NSP actually shows that we need to have improved the equitable access and utilization of quality health, nutrition and family planning service, and the 8 components to promote the healthy lifestyle choices and healthy environment. These all are the components based on the part of NCD and mental health. Now, I will be saying that something about the goal level risk factor-wise indicators that was being set up. The data was put on the December 2019, where the goal was to all citizens of Bangladesh to enjoy the health and well-being. The first priority was setting the hypertension prevalence, because it has been found that through the NCD of their research survey, as well as the BTH in every 3 years, there's a huge percentage of the people of the Bangladesh is suffering from hypertension. And among them, female are actually leading the role. The last one, which the sources has been found, we have BDHS 2017-18. The female has been found by 45%.
I'm sorry to interrupt again. Can you please click the display mode? Slide display. Yeah. Okay, thank you. Thank you.
Okay, sir. So this is the issues that we have a huge number of the female patients having the hypertension around 45% and the male 34%. And the target for the June 2022 was reductions around at least 1/3 of these cases. I'm showing some of the operational plan of the NCD's indicators as well as the unit of volume and the baseline that has been set up according to the goal as well. Now you can see that the last survey has been done in Bangladesh 2018 in the non-communicable disease, showing that the prevalence of the adult hypertension is around 45.2%, which means that every 4 of the persons in the Bangladesh is having hypertension in adulthood. And if we consider about the diabetes mellitus, there was a 2 survey, one done by the International Federation of the Diabetes, which shows the percentage 8.4% prevalence. But in our STEP 2018 survey, it was found to have 5.5%. So we are saying that obesity remains the same as 5.5. There was a large portion which names as obesity or overweight. It is around 20.3% we have this overweight in the risk groups of developing the cardiovascular diseases. So the initial target, which was set up by the NCD STEP 2010 to reduce it, the hypertension to 17%, or by June 17%, need to be revised as because the indicators has been the new items. Now relating to the mental health issue, there was another survey that's been done in the autism. In 2009, actually, it was shown to have a 0.84% the prevalence rate. But the NCD survey in 2013, which actually has been in the age group of the 0 to 9 years, shown to have the prevalence to have 0.15%. Although we do not have any new survey recently after that for 2013, a mental survey has been completed very recently in 2019, which has not been published yet. But what we have done from the NCD group is that to have the district hospitals and doctors and nurses for the training on the part of autism diagnosis and management. We completed it by June 25, and we are planning to do it 65 district hospitals. Relating to the childhood drowning is a very important component of the non-communicable disease and many of the cases of the respiratory infection. We covered to train the physician as well as the other healthcare worker in the 200 upazila, but our target is to put it to 490 all the upazila by June 2022. There's a PEN model we all know about the WHO relating to the development and implementations of the non-communicable disease management model. In our Bangladesh, we have adopted this model. Especially this is the setup where the community clinic at the very periphery will be engaged for the screening purpose of the diabetes and hypertension. And there will be a formal referring system through the e-commerce to the part of Upazila health complexes. And the target was initially is 20 Upazila health complexes and 200 community clinic by the June 2020. But the good news is that we covered already a 34 Upazila health complex catchment within the stipulated short period of 2020. And relating to the cancer registry, it was a plan to do it by June 20 over 10 medical colleges about the cancer registry, but unfortunately we could not reach that one. We have in the middle, 3 medical college hospitals has done that. So you can see that few of the items we are actually on the track. There are some progress has happened in the part of cancer registry, but of course the indicators of hypertension and diabetes need to be in the off track right now. Now, in our program of the non-communicable disease, the actual progress about the priority action plan, we had the healthy school initiative as well as public awareness campaign on the part of sugar and salt. 100 school actually was the timeline that developed. We need to go for the healthy school approach of training and other part. From the NCDC program, we have conducted meeting with the school teacher, including the headmaster and the physical exercise teacher in the 200 school on lifestyle modification. And we also share the BCC material to them. For the public awareness, the peripheral region in the form of the CHCP, health assistant, the assistant health and others in the 34 Upazila health complexes and teachers of 200 school actually was involved by the NCDC program on the part of awareness relating to the part of sugar and salt intake initiative. 10 workshop actually is conducted for the dietary salt for the teachers in Dhaka. 2 TV spots actually under is prepared. TV stall are actually running these things of the salt and sugar right now. LHPOP is actually coordinating with NCDC relating to the part. So you can see that we are actually in a good progress in this part of this salt sugar as well as the healthy school initiative. Now about the priority action plan, the annual program review in 2018, the health financing section, there was one important goal is to make available at least one antihypertensive and one anti-diabetic drug across the country at the generic cost. So that was the responsibility of the NCDC as well as LHAP, and we made it available. Now, interestingly, there's another OP, which is known as sector-wise, the program monitoring as well as the management. Now, that OP from the ministry actually has arranged another TA to actually gather the evidence to support the policy to make available at least 2 common antihypertensive and 2 anti-diabetic drugs in the generic name and affordable cost across all over the country, and that to achieve the SDG 3 target. Very successfully we have done that. We achieved this target also, getting the 2 antihypertensive and 2 anti-diabetic drugs available to the primary health complexes and Upazila all over the country. The big problem is that there's a serious amount of demand happens for the drugs. You all know that non-communicable diseases are lifelong diseases like hypertension PM. So the awareness and service availability need to be ensured for the proper management of this serious cases of the hypertension diabetes all across them. And we need the increased allocation of the fund for the drug purchase is very much important. So about the model that we are saying, there's a national protocol for the management of hypertension DM is developed. Although we have said that we need to roll up in the 34 Upazila health complex, this rolling up also has developed another 31 Upazila health complex and catchment community clinic. So right now we have a total of 65 Upazila health complex where the national protocol for management of hypertension and DM as a model of PEN is carrying out. And simply through this model, we also adopted a national protocol implementation guideline, which has developed and rolling out has been completed. NCDC is actually supplying all the antihypertensive anti-diabetic drug to the Upazila health complexes. big issue is that fund allocation of the drug purchase needs to be increased. This year we had to increase about 50 crore amount of money only for to purchase of these two drugs from our organ OP values. Another important issue is the diabetes. We all know that the insulin is a very crucial element of the management tool, and we also included the insulin in the part of OP drug list. But we also need to work a few things about the investigation, because these are the groups of the people where there's a chance of development of chronic kidney disease is very high. So if there is an available rapid diagnostic test to identify the renal function will be very important. Another important issue is the databases. Although there are hard databases carrying out, recently we have a lot of piloting is going on in different areas where electronic database has been established. And this is very important as because all the NCD activity can have a proper channel of e-base of MIS system to be developed. And also all the school need to have NCD activities, including the healthy city effort. This is another component that has been developed by the NCD. Relating to the tobacco control, which is another important of SDG issue, we developed here the IEC material. We celebrated the day every year. And also there is a high level of the political commitment. But the challenge remains that awareness of the peoples as well as the law implementation is lacking. I think a way forward will be a tobacco tax, maybe a tax ban, and awareness creation will be a very important issue. We have a component in the name of the emergency preparedness response, post-disaster health management and climate change. Unfortunately, we do not show a lot of activities still yet, because this is a new chapter of the emergency preparedness response in our country perspective of Bangladesh. Some sort of training is going on. Few drugs are purchased on the part, but we need to see that for the emergency preparedness response, we need to establish a public health emergency operations center as per the WHO guidance. What we had said that there are a lot of emergencies going on in the country, from the spot to the facility, in every step actually, for the workshop, development of the capacity, procurement needs for the equipments, as well as the EPR drugs, the anti-venom, the kit equipments, emergency trolley, all need to be set up in the perspective of emergency preparedness. We had to lot of work to be done. Now, the important component of the NCD is there are many issues relating to the part of multi-sectoral activity. Now, the good news is that we have a national level, a formation of the national, divisional, district, and Upazila multi-sectoral coordination committee, especially which is comprised of 26 ministry and division agents. We had the multi-sectoral action plan for prevention and control NCD 2018 and 25 developed. We already have a 2 national level of meeting by NCC, which is presided by Honorable Health Minister. We have few arrangements of the meeting with the BSTI and BFSA. You know something about the BSTI, BFSA because they're concerned with the safe food, prepackaged food, as well as the front of package, etc. There are many of the ministry of, MOU has developed between the NCD as well as the Ministry of LGRD, Ministry of Primary Mass Education, Ministry of Health and Family Welfare, relating to the healthy city and healthy promoting school. Now, in the district level, although we have done few of the orientation seminar, the big news is that relating to the healthy city, we have done few of the committees. There are many meetings that are in the Khulna City Corporation, and a framework on the part of action plan of healthy city Khulna has already been developed by the NCTC. Now, another component that we have, the multi-sectoral action plan, is there's a lot of challenges, especially we don't have any proper budgeting as well as aligned activities. And we also need some dedicated place, manpower for this national multi-sectoral action plan and city control coordination committee, because we don't have any secretariat at this moment. So this should be a setup to be developed. Where should we be there? What should be its policy? And it needs to emphasize at the higher policy level advocacy. We also have the occupational health hazard and environmental health hazard as a component in the non-communicable disease. Although we have few of the district level of seminar as well as workplace safety and occupational hazard, but unfortunately the challenge is that we do not have any baseline data. There is a serious amount of budgetary reconstruction, and also we have a poor non-health sector involvement, like the Ministry of Labor, Employment, BCCI, Chamber of Commerce, all need to be came together with the Ministry of Health and Family Affairs as you want to really address this occupational health hazard in the country. And we need to have proposed activity in our NCDCOP. We need to have a allocation our budget too as well. For the environmental hazard, the same thing also happened. Although we have done few of the seminars, and the health hazard relating to the part of arsenic is very important component in many of the areas of Bangladesh. We have 65,000 of the household having survey with the arsenic values in the 2012. But since then, we do not have any recent data. This is a big challenge for us right now. We also do not have any real change of health impact study data on the air pollution and noise pollution. We do not have any baseline information on the part of lead poisoning. Very recently, the soil pollutions with the organophosphate compound as well as arsenic in the agricultural product, it's been a big question for all over the globe. But we do not have any basic recent data on this part. And we also need to have a budget allocation corporation proposed activity. For the cancer is a big major NCD all over the globe. Although we have trained via the training of the doctors and nurses in 5 medical colleges, and also we have a formation of the National Cancer Registry Committee, and we have a SOP development. The big challenge is that we don't have any big budget on the part of these cancer registry. We do not have any, the country-wise cancer surveillance system. We do not have any dedicated place and manpower for that in medical college, hospital to run out this hospital-based cancer registry. But we actually try to also get some way forward. We plan in our revised OP that 8 medical college will have the same sort of cancer registry, the same form. And we also want to select a 2 Upazila where the population-based cancer registry can be started. In our component of the NCD, there are 2 important components. One is the disability, another is the geriatric and palliative care. Relating to the disability, we have developed a guideline for making training as well as the capacity development. A sign language training has been developed in the 50 Upazila health complexes. We have a sign language guideline development have been done. And for this kind of disability in the primary Upazila health complex, we established 40 disability-friendly toilet facility already. But there are serious lack of trained manpower we have seen in the primary health complexes. And we need to materialize this circulation from the PM office actually to develop a focal person for these disability people, because this is a big problem in the community areas in Bangladesh. Relating to the geriatric, we are going to have a geriatric friendly years as the years is coming by. We have developed a national guideline on palliative care. We have a few training module on this part. And in the 64 Jila, the palliative training on the TOT has been completed. For all information, there has been one statement that more than 600,000 patients are actually in need of palliative care at any time in Bangladesh. Unfortunately, less than 1% is having access. Very big challenge. And we need to also align the OP level activity with the WHO declaration of this decade of aging. We don't have any big issue of the air care, only the sign language is important for them. But this is the new area of the primary health care for us. We need a lot of activity to be done in future. Thalassemia, the same thing, we are observing this thalassemia day. 6 out of every 100 Bangladeshis actually this mutant gene. And we need a lot of creating awareness and availability service in the primary health care in future. Oral health is a big issue for our country because a large people is relating to this poor oral health has been there. And we also developed some training manual on the part. Very recently, we started developing oral health policy. It's ongoing. And it is very neglected. It's a big challenge for all of us. And we need awareness activity. Relating to renal disease is a big issue that it becomes ignorance in the part of non-communicable diseases, especially on this part of comorbidity. And we need to develop in this part. Although we have a pediatric renal disease guideline and training has been done on the TOT in 64 districts, but we recently has started to develop a guideline for this adult renal diseases of Bangladesh. Drowning is a big problem for all of us. You all know that, but we have a very good improvement on the part. NCDC in collaboration with the CBI PRB has also been doing a lot of activity, including the community day center developed children below 5 years, known as Achol, which is very popular in many of the program that has been set up. The Swim Safe is another program for the more than 5 years. Now, the challenge is that awareness of swimming learning and effective supervision of these young children is not very good in our country. And also we need to have a approval of the drowning prevention strategy, which is in the Ministry of Health for approval. But what we need is a way forward is the scaling up of this community Achol group, which is a very good initiatives below the 5 years group. But we also need to have a conduct the swimming teaching and the fast responder training through the school education program. Road traffic accident is a big component. Needs training of the healthcare provider is a big challenge. Although we have a national strategy of mitigation road traffic accident death, Also, we have done a few of the training, seminar, awareness workshop for the physicians and healthcare workers, and mass awareness going on. But we need to train them manual, not only the part of physician, but also the peripheral level of the healthcare providers. And we also need to have fast responder training, because what we are making training is the post-crash area, but the site training, the fast responder who will rescue the road traffic accidents training, and the pre-hospital management is very crucial. We need to work on that part. You all know that we have a burn institute in a town area and other things. Burn is a big problem all around the globe, the Bangladesh area. So we need to have a daycare model to be implemented. The challenge is the community awareness, but we need this scale up of the daycare model in every community clinic so that we can actually seriously make this issue an important one all over the Bangladesh. We have a serious problem of the poisoning snake bite in Bangladesh. Although we have a preparation national strategies going on the part of mitigation of snake bite based on the WHO study we started here. Procurement of the logistic has been done for the emergency management of snake bite according to a specific level. We have done the procurement of the snake bite antivenom, and the training, seminar, awareness, and the allocation has been done on the part of snake bite and few of them poisoning. But there's a gross lack of awareness in the people, as well as the gross lack of the initiative of giving the antivenom by the physician in the primary health complexes. We need to take these challenges and keep it forward. We need to develop finalize the training module for the doctors, as well as make the initiatives of how to give the antivenom in the primary health complexes. For the intentional injury and the violence against the women is the big issue. Although we are doing many of the activities relating awareness, still the community level awareness is lacking, and we need to work national survey on this part of training module to develop in future. Relating few things about the mental health, what I like to mention that this is an important global indicator of the part of suicidal mortality rate. What activity has been done is we have done 85 days training for the doctors. We have done a 2 batch, 28 days training program. We have done it 20 doctors and also 30 nurses in the 2 batches. Also, there are short course of the training on the part of orientation on mental health. Through this, 12,819 physicians and 5,800 nurses has been trained by the NCDC program. But a few of the progress has also been done in the mental health, as because we have a national mental health survey done in 2018-19, not published yet. We have developed a national mental health policy, but it is still in the cabinet division for the endorsement. National Mental Health Act 2008 has been enacted. National Mental Health Strategic Plan 2020-30 is actually developed and awaits approval for the Ministry of Health and Family Welfare. National Strategic Plan for Neurodevelopment Disorder 2016-21 has also been developed. And you will be very happy to know that Bangladesh is one of the country in this region which is selected as a part of Special Initiative for Mental Health Initiative by DG WHO. So this is a very good news for us. Nepal is another country in this part. We developed many of the IC, BCC, TV spot and audiovisual content module and guideline developed. We also have a module on the part of WHO MH gap. We have a very recently on the part of COVID-19 and mental health, develop a guidebook on the mental health, and online orientation has been.
Sorry to interrupt, Professor Abid. I need to finish this talk. Next talk should begin, okay?
Very plan on the part of short term, mid term, long term. Our aim is to have a mental health care, inclusive primary health care at rural and urban area for this one. And for the primary health care, NCD and mental health, the urban health care is a big ignorance for long, but we need to work on this part for any GP model or developing the urban dispensary or community clinic purpose or community clinic corner, at least to develop in the primary urban health care is very crucial. Rohingya is a big problem for all of us. We need to have to develop the national protocol for them, and it is also been many settings working on. We need to have organization this. Last of all, what I like to share that with this one, WHO is giving a global indicator for Bangladesh. And you can see that premature death remains at the part. We are not just far behind what our target has been set up by the global. Now, this is the premature mortality. You can see this, and the suicidal mortality is 6 per 100,000 population. Relating to the risk factor, you can see the physical inactivity, we are in this 26%. The salt intake is around 9 grams, tobacco is 23, the blood pressure is around 20. We have a range of 8% and 3 other things. Now, the issue is that if we selected the adult risk factor trends, the target that we need to go for there is here, but we are at in this level. So I think we need to work on the part of current tobacco smoking, obesity, and blood pressure and diabetes issue so that we can reach a target of the global. This is the last slide of myself. The WTO NCD progress monitor actually shows that many of the area has been completed, including the national NCD target and indicators. We do not have any mortality data, unfortunately. There are few areas of the policy strategy action plan, we are fulfilling that. But there are a few things on the part of tobacco, which is partially fulfilled or achieved. We need to work on the part of the excise taxes on the tobacco, smoke-free policy and others. We also have few things on the part of alcohol reduction issue. Relating to the unhealthy diet, unfortunately, we are lacking behind. We need to have not achieved many things like the salt strategy, sodium policy of our country, or the trans fat policy still in the very preliminary stage. But what I like to mention that while we are targeting to achieve our things in the 2030 of the SDG target, in the meanwhile, we are selecting to have some target in the 2025. Since 25 by 25 is the important issue of many of the risk factors of the non-communicable disease. And if we continue our activity in such a way we are doing, hopefully we will reach our 25 targets within the sphere of time of 25 in the region of Bangladesh. Thank you very much, sir, for giving me extra time. Thank you.
Thank you, Professor Robert Amin, for the very informative talk on epidemiology and current situation of NCD in Bangladesh. Please stay with us for the question and answer session. Ladies and gentlemen, the last speaker in today's in the present session is Professor Dr. Mahfuzur Rahman. He is a renowned environment epidemiologist and NCD epidemiologist. He graduated from Rajshahi Medical College and a PhD from Sweden, and he worked as a principal investigator in Bangladesh for vitamin E and selenium trial. He now works on as the country director of Pure Earth Bangladesh, and he will speak on the hidden crisis of lead poisoning. Dr. Mahfuzur Rahman, please. I would like to remind that you have 15 minutes. Thank you.
My title is The Hidden Crisis of Lead Poisoning. I hope you have heard the word lead from Dr. Robert Amin's word. He mentioned that there is no baseline data of lead poisoning as well as arsenic and other things. So this is not the first time you have heard this one. So I like to focus on the hidden crisis. What does it mean? I mean, what is the important currently in global situation? So we know that the WHO and the government of Bangladesh, they have instructed us to comply with COVID pandemic. So they have instructed us to wear masks everywhere. And we didn't understand or we have not complied with the hidden crisis of not wearing a mask. And as a result, we are seeing that the huge number of COVID cases. Every day we are crossing, so 5,000, 5,200. So now I would like to focus on the hidden crisis of lead poisoning. So every time we need to understand what is the hidden crisis behind the scene. So I'm Dr. Mahfuzur Rahman, as Dr. Liaquat Ali mentioned, and thanks Dr. Liaquat Ali for a nice introduction. So I act as the country director of Bangladesh country office of Pure Earth. So Pure Earth is an international INGO. It's based in the US, and Pure Earth is mainly involved to make a world pollution free. And the major work included is lead-free world. So they focused on low and middle income countries, and where the population are at risk, they try to develop a mechanism that the population can be low exposure or exposure free. So the second focus is the identification, assessment, mitigation of health risks as contaminated land. So where lead is a problem, where arsenic is a problem, so Pure Earth engage partners and governments and international organizations to make that is happen in the contaminated land. So they have equipped with the expertise in risk assessment, capacity building, and mitigation technology. And partners include USAID, UNDP, UNICEF, and United Nations of Environment Programs. So why lead is a concern? Lead is a toxic metal, and lead has no safe level. So ideally lead should be zero in human blood. Lead attacks the brain and the nervous system. So if people are exposed to lead, so the nervous system, the brain, that may be turned out as immature development. Lead, since Dr. Robaid Amin is focused on the non-communicable diseases in Bangladesh, lead exposure is responsible for increasing non-communicable disease, mainly cardiovascular disease, stroke, and kidney disease. All these three diseases have been mentioned by Dr. Robaid Amin. So lead poisoning is very important. Lead poisoning mitigation is important to control non-communicable disease in Bangladesh and elsewhere. Exposure causes permanent brain damage and behavioral problems. Lead exposure affects children's cognitive, social, behavioral, and undermines their potential. That means if the children are exposed to high level or moderate level of lead, the children cannot be developed as a full potential the children should be. So the lead poisoning is very important for children should not be exposed to the lead poisoning. So this is the statistics. Sorry for the interruption. We don't have a control on internet. So this is a very statistics of Bangladesh. So I just focused on IHME. So I don't know if you have heard the name, Institute of Health Metrics. So Health Metrics is a institute that is based in University of Washington. So they are now very popular in the globe because they have modeled the COVID cases. They are very good in modeling of death cases and global burden of disease, and as well as they are very much highlighted due to their modeling in US and other countries for the COVID deaths and COVID morbidities. So they have published a paper that 3.6% of all deaths nationally attributable to lead. So that is in Bangladesh, that is alarming in Bangladesh. So we need to act to minimize the lead poisoning in Bangladesh. So this is IQ and economic productivity. So if the 1 microgram of deciliter of lead is present in the child's blood, so the IQ can be reduced by 1/4. And economic decrease productivity by 2.4%, lower rate of high school graduation. So I just like to focus Bangladesh has the 4th highest death rate from lead exposure in the globe. So since the lead exposure is very high in Bangladesh and that can contribute deaths, so we need to act to minimize the lead pollution. Productivity losses from lead exposure cost $6 billion annually and 70% intellectual disability in Bangladesh. So all these are related with the SDG target. So if we want to achieve the SDG goals, Sustainable Development Goals, so we need to act comprehensively to minimize the lead poisoning. This industrial source, I will skip this slide. So I will just highlight some of the slides that I wrote in the Daily Star to highlight the lead, to aware the civil society and the government. The immune boosting turmeric is lead a concern. So one of the concern that lead, we can get the lead, that we have recently heard that the Stanford and the ICDERB, they have invented that the lead chromate is used to highlight the turmeric. So when we buy the turmeric from the market, so we get a lead exposure. So immune boosting turmeric is lead a concern. I focused on the Daily Star article that, so in the COVID situation, all we are concerned about the immunity, and to boost the immunity, the turmeric is a very common product in the globe. So we used to take turmeric with milk or with the curry powder. So the lead chromate is used to highlight the turmeric. So there is a way that we can get the exposure to lead. The second one that is published last week. So the killer in the kitchen. So that means the aluminum cookware. We are using the non-stick fry pan or aluminum cookware because these are produced by the ship-breaking metal. So lead is mixed with the ship-breaking metal, so we get the exposure to the lead. So there are the two ways that has been used in our household. It's very common. So the turmeric and also the aluminum cookware. The third one is always discuss about the recycled lead acid battery. So what does it mean? I mean, if you go to any countryside of Bangladesh, we don't see any rickshaw. Rickshaw is replaced by battery-led rickshaw. We call it easy bike, charger, whatever. So if we have a 10 million rickshaw in 2000, so if you go to the countryside, you will see that there will be 8 million auto rickshaw has been replaced the manual rickshaw. So how the auto rickshaw runs? The auto rickshaw runs with the battery. When it is considered as a battery, then lead is a concern because battery is nothing but a lead stick. So the huge system invented in the transport that brings a lead exposure to the whole community of Bangladesh. That is one of the reasons that we have 1/3 of the children, they have a high blood lead level in Bangladesh. So we need to act comprehensively to minimize this risk. So these are the information gaps, no inventory contaminated site. There is as usual, Dr. Robed Amin mentioned today that there is no baseline data of any contaminated metals like arsenic, lead, whatever. So in the lead history, so no inventory of contaminated site. Limited industry monitoring by regulatory agency. So always we emphasize that the government system should be strong enough, equipped with the capacity and human resource that can monitor the regular monitoring in every sector. Relative contribution of household and background sources. So we just emphasize that the aluminum cooker, if it is true, aluminum cooker can produce a lead, that has been extensively used in our household. Is turmeric can trigger the lead exposure. So we need to confirm these findings and then we need to act accordingly. So all the slide, the end of the almost slide, we are focused on children and we focused on children's behavior because the lead can cause the less intelligence. So future generation might be risk if lead exposure continues to children or children are exposed continuously with the lead poisoning. So we need to, our motion should be, that I started writing in the Daily Star, that to get the lead out. So we need to act accordingly that no lead should be in the turmeric or in the aluminum cookware or auto battery rickshaw. Auto battery rickshaw should be in the market, but there should be a system that the battery could be replaced by another battery. So there will be no environmental contamination. So now I like to highlight some of the work that we are working in Bangladesh and the globe. The PECP is a flagship program with UNICEF that has been running in 20 countries in the globe. Bangladesh is one of these. So the title is the Protecting Every Child's Potential that has been running in Bangladesh, Georgia, Mexico, Indonesia and other countries. So the second program is lead pollution roadmap. Since Pure Earth is interested with minimizing the lead, so we plan to organize the lead pollution roadmap that is funded by the USAID. So we want to make a country assessment and what needs to next, how government should act, how the donors should act, how the partners should act to minimize the lead pollution. Recently we have initiated another project that is Sustainable Manufacturing and Environmental Pollution. It's funded by UK FCDO. We work with Asia Foundation and the focus area is chromium and lead. The pilot remediation of lead contaminated site. The partners engagement, Pure Earth has developed a growing coalition agencies reduce lead exposure in Bangladesh. We have established relationship with UNEP, UNICEF, Stanford, ICDDRB, Environment and Social Development Organization, and an international lead organization. And we also working with government, and government is also welcome to participate in our program. So it's a conclusive work. So all we focus that lead can work, the brain damage, whatever. The success is never achieved by the size of your brain. But it does not mean that if you're a short stature, your brain should not be that short. It is always achieved by the size of your thoughts. So think accordingly. So thank you very much. Thank you for inviting me as a panelist of this first Congress of Epidemiology and Public Health. Thank you.
Thank you, Dr. Mahfuzur Rahman, for bringing into light a very important but hidden crisis. Now we would like to invite questions from the worldwide audience. First, I would like to invite from the audience who are present in the session. Actually, we are having a time constraint, so we will have only 5 minutes for each speaker, and we have to have a very pertinent question only. For Professor M.F. Faiz, is there any question from the audience? We would like to see also some of the questions coming from the Zoom or other participants. But if there is a question from the audience present in person, we would give preference to them. Is there anybody who wants to ask question to Professor M.F. Faiz, please?
Sir, it was an excellent presentation and a learning for us. I just wanted to know that since we are thinking of potential pandemic infectious diseases, do you think MDR tuberculosis in the era of HIV and XDR TB might be a potential pandemic threat as well? Thank you, sir.
Professor Faiz, could you hear the question, please? Is there any technical? Professor Faiz, can you hear? Can you hear us?
Now, yes, please. Yes, I hear now.
Okay. Please respond.
What was the question of Dr. Salim? It is not audible again.
Repeated. Thank you.
Sir, thank you. Sir, my question was, during this era of HIV and XDR TB, do you think we should be concerned about MDR tuberculosis as a future global pandemic threat? Thank you, sir.
Thank you. Irrespective of threat due to potential pandemic, we must address MDR TB appropriately so that we do not face XDR TB. So unless we test each and every case by expert, we cannot say. Each patient is a potential, each new patient, each retreated patient of TB is a potential MDR. That's why the current recommendation is to scale out as quickly as possible the expert. So through that, we can quickly detect whether there is resistance or not and provide appropriate treatment. I think you are absolutely right. We have lots of tuberculosis cases, but we are not appropriately diagnosing them and reporting them. Even after diagnosis, there is no appropriate reporting because the healthcare professionals, medical doctors, other professionals, they are not aware where to report. When there is the reporting system is not there. So we are doing quite good in terms of appropriate treatment of MDR TB, but this needs much more strengthening. There is geographical variation. Even after 8 divisions, 2 divisions are not, there is no facilities for treating MDR TB. So I think the MDR TB should be one of the top priority now to prevent deployment of XDR. Thank you.
Okay, is there any other question for the audience here? Otherwise, I had to get one question from another audience, Dr. Pankaj Naha, who has asked whether there is any national health future plan to prevent hepatitis, as you mentioned, very important problem of hepatitis. So he has asked, is there any national health future plan to prevent hepatitis as the prevalence of HBV and HCV is more than HIV? Do you know about that, Professor Faiz?
Thank you very much. In the current revised operational plan, there are several activities proposed in the next 2.5 years, like development of strategies. We do not have a strategy with costed action plan for hepatitis B and C, although we have got hepatitis B vaccination program, but for hepatitis C, other than this hepatitis B vaccination, there is no vaccine. So there is a plan to develop the costed strategy with action plan, in addition to what is practicing now. The National Control Program, they identified some hospitals to provide treatment for hepatitis C. You know that this is now curable within short duration. A few weeks treatment of combination antiviral drug is sufficient to treat hepatitis C. So they are using it, but this is in big hospitals. This should be available down to all district level, because this is now low-cost treatment. Many countries are implementing it as a part of the universal health coverage, as a part of ESP package. So I think as there is strategy yet to be developed, so we need to do much more related to hepatitis B and C prevention, not only by, I think one of the important thing is universal precaution. Unfortunately, universal precaution, injection safety, needle safety is not still there. Particularly, we are very concerned about the high incidence of hepatitis C among the FDMN in Cox's Bazar, where their incidence is more than 2.4%. Our one is less than 0.5%, 0.4 or 0.44%. So I think the injection safety, the appropriate disposal of these are some of the key points, but we have to have this definite strategy. I think it is very good question to address, that we need to have a quickly developed, costed strategic action plan for combating hepatitis B and C, because this is one of the SDG targets. Only 10 years before left, not less than 10 years, 9 years left to achieve it.
Okay, we will have the last question for Professor M.F. Faiz from Dr. Faria Hassin from BSMMU. She has asked, what are the major shifting of the infectious diseases in last 50 years we have seen in the history of infectious diseases in Bangladesh? Can you please respond to that?
Not audible. Not audible.
What are the major shifting of the infectious diseases in last 50 years we have seen in the history of infectious diseases in Bangladesh? A question asked by Dr. Faria Hassin from BSMMU. Could you hear? Is it audible?
Only the last part of the communication, but initial part was...
What are the major shifting of the infectious diseases in last 50 years we have seen in the history of infectious disease in Bangladesh?
It exactly matched with my lifetime in healthcare professionals. I entered in medical school in something like 1973. So since then, we have seen that we have shifted for some of the communicable diseases from syndromic diagnosis to specific diagnosis down to the community. For example, now you can diagnose appropriately some of the diseases like malaria, leishmaniasis, filaria, soil transmitted helminths, tuberculosis, dengue, down to the community with provision of treatment. That is a great shifting. On the other side, there is now microbiological facilities in terms of scientific development. There is enormous development of microbiological diagnosis, including genomic. We entered in genomic era. Unfortunately, we are far from that. So we need to have that diagnostic facilities, particularly microbiological facilities, down to district level. It is not available even in medical college hospitals in many places. So we need to do that. The major shifting is from sensitive strain to resistant strain has emerged. So I think this is another important area. And particularly the newly developed intensive care unit here and there, including in the public sector and private sector, this is a great shift from care. So this care is somewhere beneficial, but in somewhere detrimental. Without having safety, infection prevention and control policy in each and every facilities, including the intensive care facilities, possibly we shall enter soon into an era where nobody will be able to treat many infections. Already we have seen that Bangladesh is having the hints of multi-drug resistance of different varieties, not only bacterial disease, viral disease, parasitic disease. So I think the new very recent thing is we have shifted from antibiotic resistance to addressing antimicrobial resistance. So we are not talking about other microbes like fungus, parasite, protozoa, etc., etc. So I think there is method shift. Another method shift is possibly we are thinking that infectious diseases have been eradicated. So we did not try to create a specialty of infectious diseases in this country. Throughout the country, hardly less than a dozen of properly trained infectious disease specialists is there. So I think in order to tackle not only communicable diseases, communicable, non-communicable, and other diseases, we need to have a purposefully trained infectious disease specialist in this country. I think the forerunner should be these premier institutes, including BSMMU. It is very unfortunate that premier institutes that do not have infectious disease department. The method shift is we have got 5 universities, but we do not have infectious disease specialty. That's why we have got 40 specialties. Thank you.
Request one more response from you. Actually, Dr. Mahabubur Rahman from IEDCR, Assistant Professor, he has asked a question. Any initiative or policy or plan for establishment of epidemiology or public health department at major hospitals, as you concluded as the urgent need for that? Can you please respond?
Thank you. I think my conclusion has got two parts. One is related to epidemiology, another one is clinical infectious disease. For epidemiology, I think we need to have this epidemiology unit down to sub-district level, because with the USFPO civil surgeon of this type or that we are having, it will not be possible to address the various diseases in the angle of epidemiologist. So we need to have epidemiology unit in each and every places down to the sub-district. So also in major hospitals, there should be a unit who can collect reliable data so that we can have action. So I think this should be considered in a different perspective. This should be all hospitals should be patient-friendly or health-promoting hospitals. So in order to do that, there is no option but to have a link from the community with the hospital. Each and every healthcare professional should be health promoter. So in that angle, there should be a health promoting unit considering all this together, including data generation, data utilization, reliable data generation for policy things. At the same time, we need to consider the infectious disease unit and different major hospitals. So I do not disagree with him, but we have to consider in a perspective way, in an appropriate way. But the top priority should be epidemiology unit, epidemiologists in each and every sub-district. Our population is 200,000 to 500,000. This morning we listened that there will be one epidemiologist, clinical epidemiologist for 200,000 population. So for each sub-district, we need at least one to start with. So at least we need 500 to the very beginning, then next phase.
Okay. Thank you, Professor M.F. for your very nice and pointed response. For the next 5 minutes, we would like to move to Professor Robert Amin. And his first question is from Dr. Michael S. Friedman, Country Director in Bangladesh for USCDC. What can the Minister of Health and Government of Bangladesh do to realistically increase physical activity? How do we promote and encourage physical activity in ways that really can make a difference? Can we get more people to walk or walk? Can we close some road and keep for pedestrian traffic only? Professor Obed Amin, please, could you hear the question?
Yes, I heard it. Thank you very much, sir, for your nice question. Mr. Michael, I think I absolutely agree with your point of physical activity to be ensured. But the issue is that is not only the part of only one ministry, it's a multi-sectoral issue. Because when we have planned to build a residence as well as the community in our country, we forget about how to do the physical activities from the very beginning. We do not have enough parks. We don't have enough road where people can walk. So I think the planning is very important, crucial part. And many of the multi-sectoral points are a very important point. And that is the reason why NCD has developed one multi-sectoral action plan with the involvement of the many ministries. Now, these need to be worked through a secretariat. Unfortunately, we do not have any multi-sectorial coordination community secretariat still developed in our country. I think this will be a very good step if we can develop the secretariat in our country. Many secretariat will come and then make a plan how to promote this physical activity from the very beginning as well as from the childhood to the older age, and suitable environment to develop this physical activity, which is very important. Very recently, what we have done is done one component of the healthy city from the NCD in the Khulna City Corporation, where we actually have many meetings with the multi-sectorial, including the engineering department, the WASA, and the city corporation peoples. And right now they are actually planning to develop their city in such a way that so that people can really work in different time. So I think your proposal is absolutely correct. This need to be worked out. Thank you.
Thank you. There is another question. There is NCD corner in sub-district level hospital. Is there any improvised plan of DGHS for upcoming surge of NCD? And what is the plan for really NCD corners?
Thank you very much. For all the audience, what I like to mention that there's a NCD model through the plan of the WHO PAN, what we have done in the 65 districts already, Upazila health complexes. Now our plan is to get the screening by means of health assistant or the assistant health inspector or the multipurpose volunteer to screen the patients at home when they are actually going to home, their activities. And for any adult person above the age 40 will be invited to come to the community clinic. And that community clinic will screen the patient for hypertension and diabetes for at least measure NCD and also to check out other NCD component. And if they actually screen up properly, the e-system of the MIS will be developed from there. And there will be a referral from the community clinic to the primary health complex or Upazila health complexes, where we actually set up the model NCD corner in the 65 primary health complexes. Now, this primary Upazila health complexes NCD corner is actually well equipped with one nurses or one dispenser, and it is also assisted by the physician who are actually working on that time of, and the registration, the diagnosis, the treatment, as well as the dispensing of the drug of pressure and the blood diabetes, all are actually done from this NCD corner. So this is a very good hub, I will say, what our Professor M. Faiz was saying, where we can actually can have a lot of scope towards the part of the periphery of our country to get these a lot of cases of the NCD-based, component-based cases in this NCD corner. Now, the second tier is to have a referral system from this primary Upazila health complex to the district hospital, as well as tertiary care of medical college hospital. So that will be a second step, according to me, because we need to set the 492 Upazila health complexes with the ideal PAN model-based NCD corner. And if we can develop that one, subsequently the stages of this secondary referral system to the secondary tertiary can be developed with inclusion of the NCD corner at that site also. I think that should be our goal.
Thank you. I told in the beginning that this is a heavyweight session, so very large number of questions are there. I cannot, address all. We have to rationalize, ration some of the questions. So actually, some UI Mong, I don't know from which country, he has, expressed happiness to see that in both Professor M.F. Faiz and Professor Robed Amin's lecture, that UN SDG has been integrated with Bangladesh programs. But his question was, what challenges are you expecting to achieve the target? What are the changes you suggest to support the goal and targets? I think in the lectures there were enough information on that, and it would be too difficult to address these questions again in a short time, because the time is very short now. So I hope Dr. Mong will not mind to contact the speakers directly. And there is a question that for multi-sectoral action, Sahel Chaudhary has asked. I think Dr. Obed Amin was just now telling about the multi-sectoral action plan on NCD. GO-NGO collaboration is important. Could you please comment on NCD's initiative on this issue? How you are really planning to incorporate the NGOs in this multi-sector plan? Brief comment, please, from Professor Obed Amin.
Thank you very much. I think this is many of the non-communicable disease control actually needed a multi-sectoral involvement, because all I have to say that when we are concentration on the health is not just a part of the health family welfare ministry. or the health or adoption. Rather, it is always the multi-sectoral, because if you consider about the diet, suppose salt, then it is started from the developing salt, the packaging salt, the distribution and other things, and then the health issue of the how much salt is to be done, and also safety issue and all hygienic things also be incorporated by many ministries. So most of the component of the NCD is actually multi-sectoral. And when you are considering the multi-sector, definitely it's a public and private partnership always. And in the meanwhile, the non-communicable disease has done few of the activities, including the many of the private organizations actually was working neck to neck with the NCD to eliminate these things. Our largest stakeholder, WHO and UNICEF, is always there, but also the stakeholders that are working in our country on this different spectrum of the NCD is actually working through the NCD for the eliminate this important risk factor issue in our country as well as the problems. So I think there's always option, and we can work together. Otherwise, we will not achieve the target that has been set up by the SDG in the year of 2030.
Thank you. As I said that there are a lot of questions left out, and the people who have asked questions, please contact the organizers as well as the authors directly. There are emails for their contact. Now, at least one question for our last speaker, although that was a very important issue, and there are quite a number of questions, but we will take only one question from again Dr. Michael Friedman, Country Director of Bangladesh in USCDC. Lead is clearly a very dangerous long-term issue, but what do we think is the biggest way to reduce overall population exposure to lead right now? Previously it was removing lead from gasoline, but we have done that already. So what should be next? Dr. Mahfouz, please.
Thank you, Dr. Michael Friedman. I think since the main exposure earlier 20 years back was leaded gasoline, and government has taken the decision that to import the lead-free gasoline. So the government and the non-government organization should act like control the lead. So the regulatory authority, if they are active, there will be no lead adulteration in the turmeric. And the regulatory enforcement is active, then the auto rickshaw, auto battery recycle, they are listed to make them, the informal sector, make them formal, and the other exposure, the cookway, so the government monitoring and enforcement system should be strengthened to control the lead pollution in Bangladesh. Thank you.
The last question is from the one-to-one question.
I think. Thank you, sir, for your nice presentation and also nice information. I have curious one thing that in your presentation, you in first slide, you showed that Pure Earth is working in the identification of lead poisoning. But my curious is how the Pure Earth on what procedure they are used to identify the lead poisoning. And another one is 3 or 4 months ago in Bangladesh, Magura Shodor Upojela, there is a lead poisoning occurs, and from Pure Earth, is there any program taken in that area? I want to know this one.
The number one is the lead identification program. There is a USAID funded program globally, toxic substance identification program. The Pure Earth is taking the lead in the globe, and in Bangladesh, they have collaborated with Dhaka University Geology Department. They have identified initially the lead acid battery recycling site, and that they analyze the soil sample to measure the lead. Second one is the Magura incidence is led by IEDCR and CDC, and we informed that there is the incidence in Magura, and especially cattle. And Pure Earth is engaging with IEDCR because CDC is equipped with the measuring lab and capacity. So Pure Earth and CDC are working together to not to replicate the Magura incidence in other areas. Thank you.
Thank you very much. And with this, we would like to come to the conclusion. In fact, it would be very unkind on my part to talk more because the faces of the people, hungry people, I can see all around, and also probably people are waiting for a long time. So this session was very interesting. It combined infectious diseases, non-communicable diseases, and environmental and occupational health, all this. And the three speakers were excellent. They not only talked about problems, but also the prospects and what Bangladesh have done in this has done in these sectors, and also the challenges and some potential solutions. And lastly, about the hidden crisis, Dr. Mahfouz personally is present here. I would like to thank all the speakers and all the audience worldwide and who are also present here. And I would like to thank the organizers for inviting me for this meeting. Thank you very much. Thank you.